The aim of this session is to provide an overview of the metastatic spinal cord compression service for Merseyside, Cheshire and the Isle of Man. Metastatic spinal cord compression occurs where there is pathological vertebral collapse or direct tumour growth causing compression of the spinal cord, which may result in irreversible neurological damage and possible paralysis. It is therefore classed as an oncological emergency. Around 85 to 90% of metastatic spinal cord compression occurs from extradural tumours. The other 10 to 15% are intradural, either intramedullary or intradural extramedullary tumours. The epidural spinal cord compression grading system, first proposed by American neurosurgeon Mark Bilski in 2010, has been adopted by many radiologists across the region, and it helps to support decision-making regarding urgency of management. The grading system, which ranges from 0 to 3, identifies the radiographic severity of the skeletal metastases or cord compression. As a pathway, we manage urgency from a combination of radiographic presentation and patient signs and symptoms. Urgent management within 24 hours is generally offered to people with impending cord compressions or nerve root compressions where there is corresponding neurological symptoms or signs, or radiographic confirmation of a true cord compression with or without symptoms. This slide shows a clinical example of impending cord compression appreciated in a sagittal and axial or transverse view. It's possible to see that the tumour has breached the cortex of the vertebra, causing indentation of the thecal sac, but without contact with the spinal cord. So this would be graded around an MSCC grade 1B. This slide shows 4 examples, all of spinal cord compression in sagittal and transverse views through the level of the compression. The first 3 examples from left to right show epidural cord compression, and the 4th, the image on the far right, shows intradural disease causing cord compression. There are always a number of considerations when managing cord compressions, as these examples will highlight. Image set 1 shows a solitary level vertebral collapse and bony retropulsion into the spinal canal. In this case, radiotherapy management is unlikely to be effective as it will not reduce the bone that's causing the compression, and the patient would require surgical consideration. Image set 2 shows a solitary vertebral level of soft tissue expansion and tumour retropulsion into the spinal canal, meaning that surgery or radiotherapy may be treatment options. Image set 3 shows multiple levels of compression with extensive spinal metastases throughout the spine, including the posterior involvement. Pain and symptoms may not represent or correspond with the most serious radiographic levels of compression in this case, and the extent of treatment may be limited to balance patient benefit and the toxicity of treatment. The image on the right shows intradural metastases and is more challenging to manage with surgery or radiotherapy as it's commonly diffuse through the canal. However, radiotherapy can be used to target regions most likely to correspond with the patient's symptoms. Any invasive tumour or haematological malignancy has the potential to metastasize and cause cord compression, but there are some primary tumour groups in which this is more common. Based on an audit of patients referred to and treated via the MSCC pathway at Clatterbridge, the highest numbers of patients treated have prostate and bladder primaries, followed by lung, malignancies of unknown origin at the time of presentation with cord compression, and breast. The remainder are predominantly made up of myeloma, upper and lower GI, melanoma, lymphoma, thyroid, renal, and primary bone or central nervous system tumours. That may seem a huge number of malignancies of unknown origin. However, many of these will go on to have radiographic indication of a primary tumour and possible histological confirmation as well. A small number of them will, however, remain as cancers of unknown primary. In the 2023 NICE guidelines, the metastatic spinal cord compression and the spinal metastases guidelines were merged, acknowledging that in most cases these aren't two discrete events, with a large proportion of the patients developing cord compressions arising from spinal metastases. So the factors suggesting spinal metastases, or MSCC, are also progressive. So what we're looking for is a past or current diagnosis of cancer or a suspected diagnosis of cancer, pain characteristics suggesting spinal metastases, which include severe unremitting back pain, progressive back pain, mechanical back pain aggravated by standing, sitting or moving, back pain that's aggravated by straining, nighttime back pain disturbing sleep, localized tenderness, or claudication. And then to add on to that, the symptoms or signs suggesting cord compression, which include bladder or bowel dysfunction, gait disturbance or difficulty walking, limb weakness, neurological signs of spinal cord or cauda compression, numbness, paresthesia or sensory loss, or radicular pain. And in some patients' cases, a spinal cord compression may be present with only the pain characteristics that are suggesting spinal metastases. Macmillan have produced a new MSCC alert card in line with the new NICE guidelines, which are given to patients at high risk of developing a spinal cord compression, and they make them aware of those early signs and symptoms to look out for and encourage them to share those concerns urgently with a healthcare practitioner. And from clinical experience, we have found that those alert cards are allowing patients to identify those signs and symptoms earlier and present themselves, allowing for earlier investigation, earlier management, and hopefully improved outcomes as a result. The MSCC pathway was initially created on the recommendation of the 2008 NICE guidelines for the management of metastatic spinal cord compression, which advised that a single point of contact be available to coordinate the management of these patients within each region. The Merseyside and Cheshire pathway has existed since 2016, and since then the coordination team has evolved from a single point of contact to a multidisciplinary team covering the service 7:30 a.m. to 8 p.m, 7 days a week, 365 days a year, with a named consultant clinical oncologist on a daily basis to ensure rapid decision making and prompt management. The recently updated 2023 publication of the NICE guidelines has seen a merge of spinal metastases and metastatic spinal cord compression, acknowledging that these are often not discrete and there's significant overlap in the symptoms, investigations, and management required. A summary of the new guidelines written by the NICE committee is available open access in the British Medical Journal October 2023 edition. There is a focus within the new guidelines of a more individualised, patient-centred approach, considering signs and symptoms when guiding, for example, steroid use and patient immobilisation. This list is not exhaustive, but highlights the key roles of the MSCC service and pathway. So the role is to streamline referrals and clinical discussion of patients with suspected or confirmed MSCC, involving multidisciplinary expert advice from that single point of contact. To advise on required clinical assessment and imaging to diagnose MSCC and coordinate the MDT discussion regarding management of patients with impending cord compression or metastatic spinal cord compression. So on a daily basis, an MDT takes place at 9 or 9:30 in the morning with the consultant clinical oncologist, and then again throughout the day as required. Further clinical experts are involved in this pathway and the discussion depending on the patient case. The role is also to facilitate urgent surgical or biopsy management discussions with the Walton Spinal Neurosurgical team. It is to organise treatment for patients attending for radiotherapy management of impending cord compression or cord compression, collating relevant clinical information to assess their suitability for transfer and treatment, coordinate the multidisciplinary involvement, arrange transport and repatriation for single treatments from another hospital or home, to arrange beds for admission for patients receiving fractionated treatment. They also provide support for patients attending CCC for radiotherapy, and that includes emotional support and continuity of care throughout the day, conducting EH&A assessment and onward referrals as appropriate, and also telephone follow-up of patients who are discharged home following radiotherapy for cord compression. So who gets referred to the MSCC pathway? Anyone with a past or current diagnosis of cancer and symptoms or signs suggesting cord compression, the healthcare professional dealing with that patient should contact the MSCC coordinator immediately. For patients with a past or current diagnosis of cancer and pain characteristics suggesting spinal metastases, advice should be sought from the MSCC coordinator within 24 hours. For individuals with no past or current diagnosis but a suspected cancer and pain characteristics suggesting spinal metastases, these patients should be referred for urgent oncology assessment. As a pathway, we will accept referrals for these patients if there is a borderline suspicion that they may actually have cord compression. For individuals with a past or current diagnosis of cancer with lower back pain, but no clinical evidence of spinal metastases or MSCC, so those who've had recent imaging which has shown no malignancy within the spine, these patients should have the potential for changes explained to them in terms of symptoms to look out for, and they should be advised that they contact their healthcare professional urgently if their symptoms change or worsen. So for the patients who require referral to the MSCC coordinator, this normally takes two forms. The first can be a phone call. So sometimes we'll receive a phone call first and the referral form will follow on later, occasionally if MSCC is confirmed on imaging. Sometimes the referral form is completed up front and that will be emailed across to us to make us aware of a patient who may or may not have a cord compression. The MSCC referral form can be found on the Clatterbridge Cancer Centre intranet, and it's a 3-page Word document at present. There is work in progress to develop this into an online referral tool. Any healthcare professional across Merseyside, Cheshire or the Isle of Man can seek advice from the MSCC coordinators. We also accept referrals from healthcare professionals directly involved in the patient's assessment and investigations for MSCC, who are able to provide the required clinical details and order relevant investigations. A large proportion of referrals come from acute trusts in the Merseyside and Cheshire network, which includes Arrow Park, Aintree, Countess of Chester, Nobles, the Royal Liverpool, Southport, Warrington and Wiston. Most referrals come from A&E or acute oncology teams based within their trusts. Other referrals or alerts to the MSCC team come from Clatterbridge Triage or CDU, community musculoskeletal physiotherapists, GPs, cancer nurse specialists, palliative care specialists or hospices, and internal referrals from oncologists based at CCC. For patients in the community identified as high risk of MSCC, assessment and urgent MRI via A&E is the most common route. For patients known to Clatterbridge with suspicion of bony metastases and low suspicion of MSCC, urgent MRI within the week and assessment in CDU may be indicated. Advice sought from MSCC coordinators is individual to each patient case, but generally encompasses the investigations required, including their urgency, and an initial management plan pending completion of investigations and/or MDT discussion. Factors affecting these decisions are those such as whether the patient has a known cancer or recent staging, for example, do they require a CT tap, breast examination, PSA, myeloma screen or biopsy to aid diagnosis. They may have a cancer diagnosis, but there are signs suggesting the spinal cord compression may present a possible new diagnosis. Do further investigations need to be completed before giving steroids in case they affect the potential to obtain a purposeful biopsy? Can the patient mobilise while waiting for a diagnosis or diagnostic investigations or a management plan? Previously, all patients with suspected cord compression were nursed flat while awaiting radiographic confirmation and remained flat until treatment commenced. Now, with the new NICE guidelines, assessment of patients specifically for signs of spinal instability are key to individualising their care and avoiding other complications of remaining flat, such as pneumonias, aspiration and deconditioning. So advice will centre around steroids, positioning, imaging, neurology and elimination, but not necessarily conducted in that order. Where steroids are given, regular blood glucose monitoring should be carried out and patients should be offered PPI acid suppression alongside the steroids. So steroids are indicated where there is suspicion of, so the patient is clinically symptomatic of cord compression, or there is a confirmed cord compression on imaging with neurology, or the patient has a known hematological malignancy and a confirmed cord compression with or without neurology. In these cases, a 16 mg stat dose of dexamethasone is normally indicated. That should be continued as an 8 mg BD dose of dexamethasone until treatment started or a decision is made to give no treatment. Once treatment starts or there's no treatment, the dose should then be weaned, and we normally recommend halving every other day if the patient's only been on a short course of steroids. If the patient ends up on steroids for a longer period of time, weaning may be more steady. And the aim should be to stop steroids within a week of treatment. If the patient has a malignancy of unknown origin with clinical suspicion of a hematological malignancy, The choice to give steroids should be discussed with the MSCC coordinators or the haematologist on call before starting the steroids, with a low threshold for giving steroids if the patient has neurological deficit, particularly where there's rapid deterioration in neurology. The decision should be made to give the steroids. The reason not to give steroids in this particular case is that it may impact the ability to get a definitive diagnosis if biopsy is required. If MSCC is ruled out, steroids should be stopped unless they're otherwise indicated in helping with the pain or symptom management. Steroids are often given alongside the radiotherapy for a cord compression, even where the patient is neurologically intact. And this is normally where there is an ESCC grade 2 or grade 3 cord compression with or without neurology. And this is to manage the potential side effects of the radiotherapy. So rather than giving a holding dose prior to treatment to manage the symptoms, where a patient's asymptomatic, the radiotherapy may cause a flare in the reactions. Therefore, steroids are given as a preventative measure. And normally this is a short course of steroids. In the new NICE guidelines, rather than a patient lying completely flat awaiting diagnosis and treatment, immobilization refers to a supine position which minimizes weight bearing by the spine, and this could be lying flat if the patient's most comfortable or with partial elevation. If the supine position isn't tolerated, for example due to pain or breathlessness, it's advised that the position is adjusted to reduce symptoms. Early advice should be sought, ideally within 24 hours, from an expert clinician to assess the patient's symptoms through the process of remobilization to minimize the duration of immobilization required. Prior to confirmation of or ruling out of an MSCC, a neurological assessment should be completed. If the patient has no neurological signs or symptoms or instability pain, they can continue to mobilize. Case examples may be a patient with an MSCC identified on a restaging scan who was advised to attend A&E for assessment and urgent MRI, but is asymptomatic for MSCC. If the only symptom is banding pain with no neurological signs of MSCC, the patient should be sat or lay in a position of comfort and mobilise from there as pain allows while continuing to assess for any deterioration in neurology. If there are any neurological signs or symptoms of MSCC prior to imaging, the patient should avoid weight bearing while awaiting MRI to assess radiological spinal instability. So spinal instability is a combination of the pain and symptoms and also the radiographic presentation. Once imaging is completed, mobilization should be managed based on patient symptoms through the remobilization process, with a healthcare professional who's trained in neurological assessment, repeating the assessment at 5-minute intervals through the process of remobilizing. So that includes inclining from their starting position. So if they're completely flat, inclining from flat to 30, 60, 90. If they're already at 30, they can assess from 30 and continue the incline from there. So inclining from the starting position at 30-degree intervals until they're sitting, assessing sitting at the edge of the bed and sitting balance, sit to stand, transfer to chair and mobilise. If at any point through the process there's deterioration in neurology or a significant increase in pain, the patient should be taken back to the last incremental stage prior to symptoms starting. If the symptoms settle, the process should then be resumed. If the symptoms persist, spinal support can be offered in the form of a brace, and the MSCC team should be contacted. It may be necessary at that stage to discuss or rediscuss with the spinal surgical team at Walton. Whole spine MRI is the gold standard imaging modality for identifying metastatic spinal cord compression and should be used in all cases unless contraindicated for reasons which may include MRI incompatible implants or incompatible pacemaker, patient claustrophobia or inability to lie still for the duration of the scan. In the latter case, patient coaching and sedatives should be considered, and analgesia should be optimised to support the patient to be able to tolerate the scan. The guidelines advise T1 or STIR sequencing of the whole spine to identify skeletal metastases, and sagittal T2 weighted sequences to show the level and degree of cord compression. Supplementary axial images should be acquired through any significant abnormality noted on the sagittal views. If MRI is contraindicated, CT spine, ideally with contrast, should be requested, although this is suboptimal in identifying cord compression due to similar electron densities between tumour, CSF and spinal cord. In terms of urgency, if there is rapid deterioration in neurology, an emergency MRI should be acquired, and that should be undertaken in less than 24 hours and potentially overnight if there is rapid deterioration. If there is suspicion of MSCC, an emergency MRI should be acquired within 24 hours. And if there's suspicion of new skeletal metastases with new back pain, an urgent MRI should be acquired within a week. The aim of management in metastatic spinal cord compression is to maximise quality of life and improve survival, control pain, maintain spinal alignment and stability, preserve cord function and prevent cord deterioration, and maintain continence. Surgery is considered as part of the initial MDT with a consultant clinical oncologist. Indications for surgery include rapidly progressing neurological deficit, bony compression, non-radiosensitive tumour type, previous radiotherapy to a maximum dose, and pain and neurological symptoms associated with spinal instability. Where surgical discussion is required, the MSCC coordinator will complete a referral to Walton Neurosurgical Team via Orion and facilitate a consultant oncologist to consultant spinal surgical discussion with the team at Walton. Surgery may include biopsy support where the local interventional radiology team can't undertake complex spinal biopsy, or may include surgical decompression and spinal stabilization. Spinal surgery for MSCC is not a cure, and radiotherapy is often indicated after healing at around 4 weeks post-surgery. For people not suitable for surgery, this may be due to comorbidities or, not infrequently, patient choice. Radiotherapy is indicated for treatment of MSCC. Radiotherapy should be offered within 24 hours of a confirmed diagnosis of MSCC unless the patient has paraplegia or quadriplegia for more than 2 weeks and pain is well controlled, or overall prognosis is poor, and this is usually measured in days to short weeks. In these cases, the side effects of radiotherapy are likely to outweigh any benefit that the patient would gain from having radiotherapy. Orthoses, or spinal bracing, should be considered for patients with mechanical pain suggesting spinal instability, but who are unsuitable for surgery. A brace may provide some relief from pain, but won't stabilize the spine in the same way that surgery would. Radiotherapy can be considered for the treatment of painful spinal metastases or cord compression, even with paralysis. If paralysis is not acute, it's unlikely to be reversed by radiotherapy, and this would be discussed with the patient during consent, but radiotherapy could be used for pain management. The most commonly used dose fractionation regime for palliative radiotherapy or MSCC is an 8-gray single fraction. For people with extensive or bulky disease requiring a large treatment field, or retreatment where side effects are a consideration, 20 gray and 5 fractions is the most common alternative. Retreatment of a spinal level can be considered if the individual has had a good response to initial treatment and their symptoms have recurred more than 3 months after the initial treatment. As standard, the limit to treating a spinal level is twice, but this will depend on the total biological equivalent dose, the time since the previous treatment, and the volume of tissue to be irradiated. And this will all be considered by the clinical oncologist based on the potential benefits versus potential risk. Individuals previously not treated surgically should be reconsidered at this stage, as again the balance of risk versus benefit may have shifted. The possible benefits and risks should be discussed with the patient at each stage. The overview of the process for a patient attending CCC for a single fraction of radiotherapy is outlined in the table. Realistically, this process can take 8 to 12 hours, including ambulance transfer to and from CCC, and it's important to be clear about this in communicating with the referring trust, as they'll need to provide an escort for the patient. For patients attending from home with their own transport, the process from assessment to treatment completion is normally around 5 to 6 hours. A standard emergency or urgent radiotherapy treatment for palliative management would quite often be a direct posterior field. So the example on the left-hand side of the screen. So in a direct posterior field, the beam is targeted towards the area of concern, so in this case the spinal cord compression. The posterior part of the field gets a high dose, so as the beam enters the patient, we tend to get quite a high skin dose, and the dose is prescribed to the level of the spinal cord, so you get your target dose to the spinal cord, and then there's exit dose to the structures anterior to that prescription point. So in this particular case, we're treating the lower cervical spine, upper thoracic spine, so there would be some of the patient's throat in the field, so they might get some esophagitis. Sometimes there's quite bulky disease and a direct posterior field doesn't give adequate coverage to maybe the bulky soft tissue of the disease in more of the anterior vertebral body. Or the patient has quite a large separation, so to get a dose to the level of the spinal cord requires quite a lot of monitor units and therefore will get quite a high skin dose. So sometimes an ant and post parallel pair is required. Sometimes in the upper neck region, a parallel opposed pair of laterals may be beneficial to spare some of the target structures anterior to the vertebral body instead. An alternative technique takes a little bit more time in terms of planning, would be a conformal plan, normally completed with a VMAT technique, VMAT planning and treatment technique, which gives a more high dose conformal dose distribution to the target structure and tries to minimize some of the organs at risk. So indications for this might be, again, quite bulky disease that extends outside of the vertebral bodies, quite a significant treatment field, or an area of the body where there is particular concern for the organs at risk in that area. MSCC is an oncological emergency, so time is crucial. MSCC should be ruled out first, so manage as a suspected MSCC until known otherwise. If it isn't MSCC, other diagnoses can be explored. If you suspect MSCC for an inpatient or outpatient on treatment at CCC, inform the clinical team looking after the patient immediately. Complete and document an assessment of neurology and pain, or refer to somebody else who can do that. Contact the MSCC coordinator for advice. Order a whole spine MRI as an emergency and seek advice from the MSCC coordinator regarding weekend MRI provision. Refer internally to the physiotherapy team and report any deterioration in patient symptoms immediately. There is no such thing as a silly question when there is any clinical suspicion of a cord compression. So if you have any questions, don't hesitate to contact the MSCC coordinators on the email address provided or the MSCC mobile.